Management. So we'll talk about physiology and pathophysiology. We'll distinguish between adequate and inadequate airways, and inadequate breathing. Talk about how to open an airway, sometimes using airway adjuncts. We'll talk about suctioning and when you should do that. First, let's do some anatomy review. So go ahead and grab your whiteboard, if you're sitting there. Find a friend. Airways.
Are you any good at jumping at all?
Good. Somewhat.
Okay.
Okay, so air comes in through your mouth and nose. In your nose especially, it's really vascular. And as the air goes through that structure, your nasal terminates, gets nice and warm and humidified. So if you breathe through your nose more than your mouth, you won't lose quite so much moisture. And the air goes through your pharynx. You can split up your pharynx into the oropharynx and nasopharynx. So your oropharynx is more your mouth, and nasopharynx is your nose. And then as you get more inferior, you get into the laryngopharynx. And then your upper airway ends at the glottic opening, so right at your epiglottis. There's the picture. So again, it's a continuous passage, but again, we like to label things and categorize things. So nasopharynx, oropharynx, laryngopharynx. The larynx, you can call this little structure here. It's what joins the oropharynx and your trachea, basically. This little flap here is your epiglottis. Yeah, and then into your trachea, and from here down, basically, you're into lower airway instead of the upper airway. And the lower airway begins at the glottic opening, or at the top of the trachea. Your trachea starts branches into your two main bronchi, which branch further into bronchioles. And eventually you get down to your alveoli. Trachea, right and left main bronchi, or bronchus. Right where they join, that spot right there is called the carina. Bit of trivia. So down here at the alveoli, so there's just these tiny little sacs. You have all the capillaries running all over them. So this is where your gas exchange takes place. Okay. So what can go wrong? So a reasonably common EMS call that we get is an airway obstruction. And pretty much anything in there is not good. So pretty common is food for kids, small toys, anything they can fit in their mouth. kind of all ages, you'll get blood, vomit, etc. So this bullet point here, obstruction, may be the result of poor muscle tone. What muscle are we talking about? Yeah, your tongue. So if you get knocked unconscious and lose control of your tongue, it can relax and basically fall back against the back of your throat and block off your airway. So airway obstructions can be acute, like a minute ago or a second ago it wasn't there and now it is, or can occur longer, slower acting over time, but still end up in an airway obstruction. So acute things, think foreign bodies, vomit and blood, and then more over time, like airway swelling from burns, or infection, or trauma, or a more gradual decrease in mental status. You can also just have the lower airways, your bronchi constrict, so those things have a smooth muscle in them, so they can expand and contract. They also have a lot of mucous membranes and can produce excess mucus. So think your airway obstructions, anaphylactic reactions, that kind of thing. Asthma. Sorry, airway obstruction. Asthma. All right, so when you're looking at somebody's airway, basically you want to know, is it open? Are they moving air? Or are they not? And then, will it stay open? Your patient is, again, awake and talking to you, then they have an open airway. Unless they're making choky sounds and coughy sounds. For your unconscious patient especially, you need to take measures to keep their airway open. So remember, if at any point you lose your airway, lose a patent airway, then patient is not going to do well. So you always got to be watching, checking your airway. So signs, symptoms, or findings that indicate airway problems. If they can't speak to you, if they're awake and not able to speak to you, obviously that's a pretty significant emergency you need to correct pretty quickly. Raspy quality to your voice. Stridor is a particular lung sound. You may know what stridor is. So it's pretty similar to a wheeze sound, so it's kind of a high-pitched whistly sound. The important thing for a stridor is it's from your upper airway. And it's usually caused by an obstruction in your upper airway. Air kind of tries to whistle past it. Snoring is just what it sounds like. Your tongue is starting to get sucked back to your throat and snoring sounds. Gurgling. Sounds like you're breathing through fluid. More signs, if you actually see something in the airway, vomit, fluid, blood. If you can't detect that air is moving. If their chest is not going up and down. If they have excessive abdominal breathing. Let's remember, young kids, infants especially, tend to be more belly breathers, so that's kind of normal for them. But adults, usually, you know, you breathe with your chest and not so much with your belly. If you're noticing a lot of belly movement with an adult, that's a sign of them having a hard time moving air through their airway. For kids, you can also see retraction sometimes and nasal flaring. So nasal flaring is just that, their nostrils flare up when they take a deep in breath. In retractions you can usually see under the clavicles, so it's like the space in between their ribs is getting sucked down because they're trying to breathe so hard. Okay, so you're looking in their mouth, you're seeing if their airway is open. If you find that it's not, you need to fix it. So for somebody that's passed out in a supine position, we're going to do this head tilt chin lift or a jaw thrust. So your head tilt chin lift is just that. You're going to rock their head back, lift their jaw forward. With adults, it's kind of hard to do this too far back. Airway structures are rigid enough, they're not going to get obstructed by doing that. For kids, you can do it too far. The jaw thrust we use when we think they might have a C-spine injury and we don't want to be rocking their head back and forth. So in that case, what you do is you just take and use your fingers and you're pushing the jaw this way. So if you feel behind the angle of your jaw, you're going to push on your front of your cheeks and push the rest of your jaw forward. That's the idea that you're dealing with a jaw thrust maneuver. So the advantage of the head tilt chin lift is they'll typically kind of keep that position after you let go. With a jaw thrust, if you're needing to do that to open the airway, then you got to stay there that whole time and keep jaw thrusting, because otherwise the jaw just goes right back. Again, the idea is to not tilt or rotate the patient's head. So after you open the airway, you need to keep the airway open and keep it clear of fluid, vomit, blood. Kids have big heads compared to the rest of their body, and so when they're lying flat, they'll often end up with their chins on their chest kind of thing. And so pretty frequently you're going to need to put like a towel or blanket or something underneath their shoulders to keep them in a more neutral position. Okay, airway adjuncts. So when you do a head tilt chin lift, like I said, it's more likely going to stay there until you start moving the patient around. But the jaw thrust, not really a long-term deal. So airway adjuncts can basically secure that airway better for a longer time. The two that you're allowed to use are the OPA and the NPA. So your oropharyngeal airway and your nasopharyngeal airway. So one goes in your mouth, one goes in your nose. So this one is the NPA, and that one is the OPA. So the OPA, the one that goes in the mouth, goes right over your tongue and right back to the back of your throat. So you can only use it for patients that don't have a gag reflex. If you try and just stick one of those down somebody's throat, it'll hit their uvula and it'll kick that gag reflex off and they'll they'll at least dry heave, they might vomit all over you. So you can't use an OPA on somebody that's awake, basically. Most of the time when we're using OPAs, it's when we're doing CPR on somebody. We'll practice putting these things in on the airway mannequins, but there is yet to be an airway mannequin developed that has a tongue that's like a real person's tongue. So with an airway mannequin, you can't really push the tongue in the back of the airway, but for a person, their tongue is just kind of floppy and hanging out in there, and if you just jam that thing in there, it can push the tongue back. So to put it in, we'll put it in kind of sideways and rotate it in place. Have your suction ready, just in case you misjudged and they do have a gag reflex. You hit their uvula and they start puking on you, you make sure you can get that out of there quick. If they do gag on it, then pull that sucker out of there. And try and maintain your head tilt chin lift even after you do the adjunct insertion. So your OPAs come in lots of different sizes. You can get these things down to the smallest little baby you want or don't want to ever have to use. The idea is just to keep the tongue away from the back of the throat and provide an airway passage around the tongue. So to measure these things, going from the angle of the jaw to the earlobe, that's a good way to size it. You can go from the nares to the angle of the jaw there too, and that'll get you a ballpark anyway. Open their mouth by doing this little scissory technique thing. And you can insert the airway starting kind of upside down, or you can insert it starting sideways. And again, the idea is that you don't push the tongue back into the back of the throat that way. For kids, the top of their mouth, the hard palate there isn't as developed, and there's risk of damaging that if you start sticking stuff in backwards. So for kids, we don't rotate the thing. We don't start it upside down and rotate it all the way around like you can for an adult. You can usually go sideways and get it in there, but we don't do the full 180 thing for kids like you can for an adult. And we'll practice with the mannequins. Questions on OPAs? So then NPAs are a nice little soft flexible tube. These things go in your nose with the same idea as to go in between the tongue and the back of the throat so that you get an airway passage. So since it goes in through your nose and goes behind your uvula, you can use these in principle on anybody. So they can have an intact gag reflex, and you can stick one of these things in somebody's nose. In theory, and anybody in the room here could have an NPA. That being said, they're fairly painful, so it's not something you want to use just kind of at random. You don't want to stick an NPA in if you think there's cerebrospinal fluid coming from the nose or ears. And the reason is that means that they likely have some kind of facial fracture or cranial fracture, skull fracture. And you don't want to accidentally stick one of these little NPAs in their brain. Because this is more or less a blind insertion thing. You just jam it in their nose. So if you have that CSF, cerebrospinal fluid, coming out their nose, then you don't use an NPA. Otherwise, these things are not really contraindicated. Yeah.
So let's say the patient did have an intact gag reflex and that there was the CFS present. What would your best option be at that point?
Call for more advanced provider and get them intubated probably. Drive real fast. Yeah. It's not going to be a good situation, I guess, is the thing there. Yeah. So NPAs come in various sizes too. And you measure these things from the nares to the earlobe. Realistically, you kind of just want to use the biggest thing that'll fit in their nose. The bigger they are, the longer they are. And as you'll see on the mannequins, the smaller, shorter ones, they're easier to get in, but they don't go typically far enough back in the nose to get behind the tongue. So, none of those things, none of the nasal airways are so long that they're going to get somewhere dangerous. We carry them all the way down to like the 24 size. That's actually a 22. So NPAs, you lubricate them a little bit. And then you kind of just open their nose and stick them on in. If you meet resistance, you can pull it out and try the other nostril. We don't keep trying to jam these things in if they get stuck. Those nasal terminates in there are pretty vascular and they will bleed a fair bit if you start tearing them. These things are pretty soft, so if you're not, forcing them in there too hard and you've got them lubed up, then the likelihood of doing damage is pretty small. But if they get jammed up, you can't just keep jamming them. Questions on NPAs? Okay, suctioning. So suctioning is how you get liquids out of the airway. And there's a variety of devices that we can use to provide that suction. So basically, you need some kind of source of suction, so that can be a battery-powered device, it can be a hand-operated device. You need somewhere to hold all the fluid you're sucking up. You need some tubing and you need a suction tip. So we have both portable ones and the fixed type. So the fixed type is what you're going to see mounted in an ambulance. And it runs off the power of the ambulance versus the battery-powered guys, which is the same basic principle, just battery-powered machine. Skip right over that. So the tips, a fairly common one is this Yankauer tip. So that's just a large plastic catheter that that you can use to suction stuff right to the back of the airway. The holes on the end of this thing are not super big, so it doesn't suck up chunky stuff. It's not going to get whatever roast beef soup or whatever, any kind of thick stuff. General rules here: suction only as far as you can see. So you're not allowed to suction down into the lower airway. We just do upper airway suctioning. That vagus nerve runs right along the back of the throat. If you run your little suction tip back there and run it up and down, push it on the back of your throat, you can cause a vagal response, especially in kids. If you hit the uvula too much, you can get a gag reflex, although typically here if we're suctioning, they don't have a gag reflex at that point. Another option for your suction tip is these flexible suction catheters. Some people just call them French tip suction catheters. These guys are nice and skinny, and you can pass them into a nasopharyngeal tube or through an endotracheal tube. We carry these things in a bunch of different sizes. The bigger the number, the bigger the tube. So these things, just like the Yankauer tips, are not big enough to suck up big stuff. When you're suctioning with these things, you shouldn't suction further down than you can see, so we're not allowed to suction into the lower airway. But you can suction to the back of their mouth, so you can measure that thing just like that, mouth to the edge of the earlobe, and then only insert it no further than your fingers where you're holding it, basically. So when you start suctioning, you're sticking something in their mouth. Again, there's a risk that you're going to hit that uvula and trigger a gag reflex, possibly some projectile vomiting. So if you just as soon not have vomit in your eyes, it's a good time to put on some goggles or a mask. You generally don't want to suction for more than 10 to 15 seconds at a time. But if there's more vomit in there than that, we also don't want to bag that vomit down into their lungs. So if it's light stuff in there, and you're not worried about it getting deep into their lungs too much, then 10 seconds, okay. You can't just sit there minute after minute and keep suctioning. You got to breathe for them at some point. But again, you don't want to push all that fluid deeper by bagging when that's not clear. It's kind of a damned if you do, damned if you don't kind of situation, but it's generally a good idea to just keep suctioning until the stuff is out of there. So when you're suctioning, you stick the device in there and then engage the suction, so you don't suction as you're inserting the device. Most all of the tips have some kind of little thumb port that you cover up, and that's what starts the suction at the tip of the device. So you stick it in there and then start suctioning, and you suction on your way out. Questions on suctioning? definitive care. So Maddie's question, what do you do if they need an airway and they have the CSF stuff? Well, you're kind of screwed. So sometimes things are going to get beyond what you can do as an EMT. And you might need surgical procedures, you might need endotracheal tubes, you might need a paramedic. So I guess the idea is just to realize when you're in over your head and call for help early. So we pretty much always have at least one medic available in town. I mean, it could be that they're out on a medic rendezvous or out on another call when you need them, but usually if you need a paramedic, you can get a paramedic. Occasionally, it's just going to be easiest to drive to the hospital fast. Most of the time, we're not more than 5 minutes away from equipment. Actually, our medic rigs are newer than that now, but we have like 13 paramedics. At least one is on duty all the time, if not two. So, okay. Other considerations: facial injuries. So, skull and face are pretty vascular. When you get injuries there, there's lots of bleeding. And it's hard to keep that open. Hard to keep that airway open. In the end, you're going to need an advanced airway. Obstructions, so if somebody swallows something like a marble or something, I mean, you're not going to get that out with your little suction tip thing. You might need to do abdominal thrusts or chest thrusts. If you can see something in there, you can finger sweep for it. We don't do blind finger sweeps because there's a risk you're going to push something in deeper. If you see something in somebody's airway that you can reach with a finger, fine, you can reach it with a finger. In the medic kits and in our code kit, there's laryngoscopes where a paramedic can open their airway a little bit more and get in there with a special pair of grabbers called McGill's forceps. And they can reach down in pretty far and grab stuff. Dental appliances, so like dentures. In general, if we can leave them in, then we'll leave them in. But if they get knocked loose, then pull them out. Kids, again, smaller mouth and nose. Their tongue is bigger, and their trachea is smaller and more flexible. We've had this little plot before, or this graph before, but just remember their tongue is proportionally larger, so it's easier to fall back. And in general, if kids are having cardiac issues, it's because they're having airway issues. If you can maintain the kid's airway and get them decently oxygenated, then you've kind of fixed most of their problems, typically. With kids, you can't get their head back too far, otherwise you can pinch off their airway the other way. So we don't hyperextend their neck. Again, with adults, you can pretty much crank it back as far as it'll go, and that's okay. With kids, not so much. We don't have NPAs that fit little bitty kids. So like a 22 is about as small as we get. And so you're looking at, maybe a 12-year-old or something might be able to fit one of these things, but much much younger than that, and you're down to just the OPAs, and you got itty bitty OPAs. So imagine the size of the kit that yeah, try and keep off the back of the airway, avoid that vagal response, especially with kids. If you vagal them down, then they're not going to be moving as much air, and you've just caused them more issues.